So my today's topic, what I'm going to talk about is when to consider which type of a fusion. And as you all know that right from when the fusion started in 1911, there are so many types of fusion which have been which are there. And in last 10 years, I think there is a blast of different types of fusion which are there, and there is a lot of confusion. And therefore, uh, why this topic matters. And this topic matters because whenever we do a lumbar spine surgery, world over, whatever the forum is, there are definitely debates on two aspects of it. And the first aspect is when to fuse, which I'm not going to talk as in my today's lecture. But out of so many techniques which are there, which technique to be used? And that is what is going to be my focus. And why this focus? Because there are so many techniques which are there for fusing the spine, right from anterior fusion to lateral fusions to posterolateral fusions to the posterior fusions. And there's a rapid expansion of MIS techniques in all these methods of fusion. So there are multiple corridors which are treating the similar pathologies. Like if you say that single one level or two level fusions for, you can do it by any of these methods which I have shown in this picture. And it is equally performed not by open, but by an MIS way, by tubular way, or by an endoscopy. So there are so many ways in which one can approach the same pathology. And therefore, I found that there is a need of pathology-driven corridor selection and algorithm rather than debating on which fusion and which techniques or when to use which type of the fusion techniques. Now, if you see the fusion techniques that which are there, which I described before, all these fusion techniques, they differ in approach. They differ in use of technology. You can do the same thing with different types of technology like robotics or navigation or fluoroscopic or open, any type of technology. There is a difference in minimalism. That means you can go from open to MIS to an endoscopy. And as you go from open to endoscopy, the minimalism increases and you can have less tissue damage and less tissue trauma. There's definite difference in learning curve, and this is dependent on each and every individual surgeons and their choice. And each technique, if I say ELIF, then it has a different learning curve. If I say lateral fusions, it has a different learning curve. If I say endoscopy, it has got a different learning curve. So whatever the technique that you use, each and every technique which have a different types of learning curve. There is a difference in choosing the technique depending on the levels. That means if you want to do an alpha S1, there's a different technique. If you want to do laterals, then it is a different technique. If you want to do L1-2, you can approach differently. So there's also difference in which technique to be used in depending on the multiple levels or single levels that you are doing the fusion. There is a difference in achieving radiological parameters. And this is one of the very important aspect that we should talk about as on today. And we all know that achieving a good lordosis is one of the key aspect to get a good outcome of the surgery. So there is a difference in achieving radiological parameters by different type of surgeries. And with each technique, there is a difference in safety and complications. This can be either surgeon related or even region related. There are certain regions who are much more well versed with an anterior approaches, while there are certain regions which are not well versed with the safety factors going from an anterior or abdominal approaches. So there is a difference in the safety and the complications for each and every technique. And each and every surgeon is different, and their perspective of looking at the technique is quite different. And there is also a surgeon's perspective which is involved when you choose the fusion technique. So there are so many differences, and that's why, because there are so many fusion techniques, so many fusion differences in these using of these techniques, I think there is a lot of confusion which is there while choosing a technique. So just considering my whatever I have gone through in my experience of last 30 years, we started with an interbody. I think interbody was the primary fusion technique which is evolved compared to the posterolateral. And if you see the interbody, which I'm going to just focus on the interbody fusion, then in 1990s we were doing the PLIFs. Then in 2000 we started with TILIF. Uh, but that was a stage where we started with TILIF with the cage. Then came the perspective of minimalism around 2007 and 2010. In 1920s and in 2020s came further minimalism in form of an endotelief. And then in between, the laterals and endocaliph, they have come in the way of different types of techniques. So if you see, there is a vast array of different types of fusion techniques which are there. And there are a lot of intricacies in choosing these different techniques which are there right from 1990s. More or less, if you see these two techniques of from PLIF to endotelief or an OLIF to endocaliph, then there is also a difference in whether to go for a direct decompression or an indirect decompression. So even there is a philosophical change when to use indirect decompression and when to use the direct decompression. So there is a wide array of difference in different types of technique. But one thing is very common, that whatever the new technique which is developed, it shows a clear benefit to the patient and the surgeon. For the patient, it is important to get a better outcome. And for the surgeon, the techniques become more and more easier. I know that once we were doing PLIF, it took about 7 to 8 hours. And now you can do an endocaliph within 30 minutes of time. So there is a lot of difference. Even the techniques have become very much easier than what it was before, than when we started. Coming to a little bit of historical background, why everything started in 1943, it was Cloward who started with the interbody fusion. But at that time, there was no instrumentation. So he gave a principal concept of an interbody fusion, but he failed because it was an uninstrumented posterolateral, uninstrumented interbody fusion. It failed, but the conceptually wise, it was very well accepted. And therefore, the further change came that if you have instrumented interbody fusion, it gives much better results. And Professor Arthur Steffi developed his own instrumentation system, and which worked very well in 1990s. And we were using all these Steffi plates and techniques in 1986, which was facet preserving. You used a tricortical graft instead of, there was no cage concept at that time, but you have to insert the graft from both the sides of the dura. So there's a lot of manipulation of the dura. But because there was no anterior column support and the graft collapsed, so there was a higher graft, higher subsidence rate, and there was a lot of implant failure because of the system also, which was quite rigid and bulky system. So we changed from that by biomechanically. We started with a structural anterior column support, which was given by Professor Eugen Harms in 1996. And then we know about the 80-20 concept, that you have to give an anterior column support. And since then, he started with this. This was the case that we used in late 1990s, where he gave the mesh cages. But conceptually, he gave the concept that you have to have an anterior structural support to get the best outcome, and that's how the TILIF with advantage of cage concept came in 1996. Now there are different wide varieties of cages which are available, and we are not using titanium mesh, but there are so many types of different types of static cages as well as expandable cages which are available. But concept remains the same, that you have to support the anterior column. And therefore, TILIF has remained the gold standard technique for interbody fusion. So no matter whatever technique or whatever types of cage you use, TILIF is a primary procedure whenever you are doing an interbody fusion. And it gives a good radiological alignment, and it gives a good radiological fusion rate around more than 90%, because you are able to completely clear the disc space and put a lot of graft anteriorly. And that's why it has remained the gold standard technique. And this remained for a very long time. For around 10 years, we were all doing the same thing. But principally, the next change came by Professor Kevin Foley when he started, he first gave the concept of a tubular retractor and preservation of the muscle. And that minimalism was the first time that we found in 1997 when he started using the tubular retractor system. And there was a less collateral damage. We did the same thing what was there in TLIF, in open TLIF, but the main concept was protection of the muscles. And this protection of the muscles reflected in the outcome of the patient. And you can see the patient had less muscle damage. The patients were discharged the next day. They returned to the work faster compared to the open TLIF. And therefore, as on today also, MIS TLIF is one of the gold standard techniques for the lumbar interbody fusions. But doing that, you require definitely a magnification and light, which was provided by a microscope by the tubular retractor. And that's why we did minimal invasive surgeries. Now, from that came we of course we started doing that in 2007. We published our article, the first article, which was 23 consecutive cases, and in different types of indications, right from listhesis to revision surgeries to lytic listhesis. And that's a revision surgery which was there not from a single level but also in multi levels, that we started doing this type of MIS TLIF surgeries. So which was applied, and it has changed the whole thinking process, that from open, the whole world has changed from open surgery to an MIS type of surgeries, and preserving the muscle, paraspinal muscle was the key, which was a key step forward, which was given at that time. Coming to this evolution further, and now it has further evolved, the minimalism has further evolved from an MIS technique to an endoscopic technique that we are doing as on today, which is the least invasive, which gives a similar outcome as an MIS TLIF, which gives a cosmetic incisions and sometimes a totally percutaneous procedures. So it has totally changed, right from big incisions and big scars. We have come to the era where we can just do all these fusions percutaneously. So there is a vast change from where it started all. And the biggest advantage of an endoscopy, and this is just to compare that this is what is the microscopic picture, and this is what is an endoscopic view, where you can see that there is, because of the irrigation that we have, and because of the endoscope, you can have a good amount of magnification. There is a lot of clarity in the picture that we can get by an endoscope. And therefore, the world has moved from microscope to an endoscope. And we are using a lot of endoscopic techniques. So for a fusion, when we say from a monoportal or biportal, I think biportal becomes much more versatile for doing a fusion technique. And because of the clarity of the vision, you can see the magnification which the endoscope gives. This is a dural surface, and you can see very nicely even the capillaries, which can see the clumped RBC which are going. And that's the amount of magnification that you can see with the help of the endoscope. And why biportal? Because you can get any angulations, you can use any type of drills or burrs, and this is what I use is the ultrasonic bone scalpel for removing the bone. So you can work at the corners, and it's a versatile approach for doing the fusion. And therefore, UBE for the fusion is much better compared to the other techniques for this thing. So this is just a case of L4-5 listhesis. You can see that there was an disc with a listhesis there, and the same similar thing what we were doing as an open through the tube, and now with the help of the UBE, That's the interlaminar area, that is the pars area, and you can see the facet joint there. And you can do the same resection. This is an ultrasonic that we are using. You can do the same resection of the IAP. So that's the IAP which has been resected by the ultrasonic, and it gives a much better clear vision, and the whole piece of bone can be used after you removing the IAP. That's the tip of the superior articular process that is removed, and the rest of the procedure more or less remains the same. The only important part is because of the irrigation and magnification and clarity of the vision is so good that the chances of getting a complication rate is much less. And you can do much better work than the microscopic, and you also can go inside the disc space and completely clear. And you can see that this is how you can prepare the end plate, and you can visualize the complete end plate. So the scope, and you can see the end plate preparation, which is much better by the endoscopic method compared to this is you can never see with the microscope, and then putting the cage inside. And therefore, the next step which came from an MIS TLIF was an endoscopic fusion or an endoscopic interbody fusion. These are the cases that we have done through an endoscopic. That's another UB that was again a lytic listhesis with the up migrated disc. I'm not going to show the same type of videos, but just showing that these are the cases which can be done. So now the question comes, what is better? TLIF versus MIS TLIF versus a UB TLIF? And what does the literature say? Because my base is going to be what a fusion technique that we should use. Every technique has got their own advantage, but whether it is clinically beneficial to the patient and how far a surgeon can go for minimalism. So this was latest article of 2026, which I am presenting. It is 93 patient in each group of open TLIF, MIS TLIF, and UB TLIF. And it was a matched pair, age matched, sex matched, body mass matched, mineral density matched, everything was matched. And you can see the conclusion that if you see the operative time, open TLIF has the least operative time. If you see the intraoperative blood loss, UB TLIF has the least blood loss. If you see the fluoroscopy use, open TLIF has the least fluoroscopy use. If you see the incision length, UB TLIF has the least incision length. Post-operative drainage, UB TLIF has the least drainage. Post-operative ambulation time, early ambulation with the UB TLIF, hospitalization, early discharge by the UB TLIF. So compared to all these three, UB TLIF has a definite advantage. But there are the functional outcomes. If you see the functional outcomes, so that was the perioperative. But if you see functional outcomes, I don't think there is much a difference between the functional outcomes at 5 years, whether you do open TLIF, whether you do MIS TLIF, or whether you do UB TLIF. So it is in the early postoperative phase that this minimalism works. And the same finding, this is again from the AO Spine Global Spine Journal 2026. What is the difference between the tubular retraction and the biportal endoscopy? Operative time is shorter for TLIF with a tubular retraction. Biportal has got a longer operative time, but rest of the results are much comparable. That means if you see the patient back reported outcomes, they are comparable. The only major difference is in the intraoperative visualization, instrument maneuverability, and learning curve. Learning curve is much less with the tubular retraction, and learning curve is much more with the biportal endoscopy. And that's where it matters. Outcome remains the same. Maneuverability is much better with biportal endoscopy, but the outcomes are the same. The learning curve is much more with an endoscopy. So here also the surgeon should know that if you are well versed with the endoscopy, then yes, it is much better, but it has a longer operative time and longer learning curve. The similar outcomes which are there in different reviews. So the key conclusion, for a single or two level fusion, Open TLIF gives robust functional outcome and radiological outcome. It has greatest tissue trauma and blood loss. MIS TLIF is in between. It reduces the tissue injury than open. It has a faster surgery compared to the UB TLIF, and it has also a good radiological outcome. The only difference is it has an increased radiation and it is more invasive than UBE, but less compared to the open TLIF. UB TLIF has got all these advantages, but it has a definitely longer operative time and a learning curve. But once you master the learning curve, of course, you can decrease your operative time also. So these are the conclusions of the single level. What are the disadvantages? Now we come to the disadvantages of the TLIF procedure. There are approach related morbidities, like you have to do a bony resection, there is an epidural bleeding, there is a chance of incidental deuterotomy, is a direct neural injury, perineal fibrosis. So they are all the complications. Whether you do MIS or endoscopic, these things remain the same. Maybe a slight difference in the rates, but they remain the same. And even the biomechanical issues remain the same. Like you have a small footprint cage, the cage subsidence rate is going to be higher. And the biggest problem is in the multi-levels. If you want to do a TLIF, endo-TLIF in a multi-level, MIS TLIF in a multi-level, and how much segmental lordosis that you can achieve, which is a big point of discussion when you are doing an endo-TLIF or an MIS TLIF. So lordosis achievement or achieving a good amount of sagittal alignment is very, very important, as we all know, because if you don't achieve a good amount of segmental lordosis by putting the cage, you are definitely not going to have a good functional outcome, and you are increasing the chances of adjacent segment disease. And this is what is very well even literature describes. I'm not going to go, but you can see that if you see this, there's a positive balance. If you have a good lordosis, you can have the whole curve which is corrected of the spine. And that's where there's the importance of getting a good segmental lordosis and an overall lordosis, which affects not only the lumbar spine, but it affects the whole curvature of the spine. And that's where the advantage is to get a good segmental alignment. So you have to have a normalization of the lordosis, and which improves the functional outcome of the patient. And if you don't achieve, and there is a consequence of a hyperlordotic construct and adjacent segment degeneration, which is much more feared in the in spine, because whatever amount of fusion you do, you are going to have some amount of adjacent segment disease, which you cannot deny. And more so, if you don't achieve a good segmental lordosis, you are going to have this. So this is what in 2004 we did the TLIF, and in 2013 the patient came back. And why the patient came back with their adjacent segment problem? And that was definitely because we could not achieve a good amount of segmental lordosis. Once you don't have a good segmental lordosis, you are going to have a compensatory upper level degeneration and a problem. And this is what we had to revise. Similarly, a two-level problem, can see we did not do a good amount of get a good amount of a lordosis. It was a straight spine. If you have a straight spine, no matter good fusion that you have, you can see a very nice fusion at a 5 years follow-up. But then the patient had adjacent segment disease. So we had to have a good sagittal alignment later on to get a good surgical outcome. So it is important to have a segmental lordosis even in single or two level spinal fusion. And this is the crux, whether you do open, whether you do MIS TLIF, or whether you do an endo TLIF. If you cannot achieve a good amount of segmental lordosis, you will get immediate good outcomes, but long-term outcomes will be affected because of this. And this has been very well studied in the literature, that the segmental lordosis in MIS TLIF with the static cages is nearly less or half than the lateral fusions. And this is it's very well is there in the literature. So there is nearly double increase in segmental lordosis after lateral fusion compared to MIS TLIF or static cages. If you see, it's around 2.1 degrees of a segmental lordosis that you get, whether you do an MIS TLIF or a UB TLIF, you can get a good fusion. but you cannot get a good segmental lordosis. So this is a very, very important point. The other thing is, if you want to do a multiple levels in more than 2 or 3 levels, MIS TLIF or an endo TLIF is going to be a big problem, because you are going to have a lot of time constraint doing in the multi levels. So that is also one of the restrictions. So MIS TLIF or UB TLIF is a challenge, and open TLIF is an invasive. And here comes the importance of the other fusion techniques which are scoring over this MIS TLIF or a UB TLIF. So a TLIF is good for singular 2 levels, achieves less segmental lordosis, and UB or MIS TLIF is better than an open TLIF if you want to do a singular 2-level TLIFs. So then comes the lateral fusion, and OLIF has a big advantage in lateral fusion. It improves the visualization and access to the disc because you are going directly lateral. The cage position is quite anterior, and you can jack up the disc space. And so biomechanically, it is much better. You can get a very good segmental lordosis compared to the MIS TLIF. Clinically also, the patients, it's by an MIS way, so you can do all the parameters of short operative time, hospitalization, reduced blood loss are also present if you are doing these OLIF procedure. It is a very good, it gives a very good sagittal alignment in the whole spine compared to the single level or 2 level. It is a very good for versatile for multi levels. It gives the best fusion rates because you can have very good clearance of the disc, and you are using a very large cage compared to the posterior TLIF approaches. And because of that, it has got a lower rate of adjacent segment disease, and revisions are easy because everything is virgin from the back. And it's a truly minimally invasive and muscle sparing and more physiologic, because you are not destroying the posterior structures at all, and therefore it is much more physiologic compared to the others. And we studied this part of the lateral fusions, and these are our publications, and we started before 10 years, and these are all our publications in last 10 years. The first thing is whether the indirect decompression works or not. And we published in 2019 of 60 segments that in grade A, B, and C of lumbar spinal stenosis, OLIF definitely works. Then there was a problem that when it is difficult to do an OLIF in Indian patients, and in 10.56% of patients, there is no corridor where you can do a lateral approach. And that's where the complication of the vascular injuries occur. So you should know when you should do this, when you can do this procedure. And in 10.56%, it was not possible to do a lateral approach. And this is what from our publication. This is also our publication, which was published in 2025. And you can see a canal expansion. So that was a pre-op, that is immediate post-op, and that is 3 years follow-up. And you can see the whole indirect decompression works. You can see a complete canal opening in 3 years follow-up. So Shiza's grade C was converted to Shiza's grade A without any direct decompression. It was all the indirect decompression affected. This is Shiza's 4, and then you can see that in 3 years time or 2 years time, it has completely opened up the canal, and there's a remodeling of the canal which occurs. And we followed these patients for nearly about 5 years, and the spinal canal area improved around 135% in 5 years, or minimum 3 years follow-up of these patients that we had. And 83% change from grade A stenosis to 83 from grade B, C or D to grade A stenosis. And that's a quite huge amount that that is there in this. Coming to the key aspect of the lordosis, which is also one of the important factor, and that this is what again we published, which was published in 2025, how much segmental lordosis and lumbar lordosis that we can get after an oblique lumbar interbody fusion. And the mean change in segmental lordosis from preoperative to postoperative is 5.23 degrees compared to TLIF, which gives around 2.1 degrees. So definitely lateral fusion gives much better segmental lordosis. And if the cage position is anterior, it gives much more better lordosis is around 6.29. So if you see this case, and this is an anterior, you can see that from here to here, if the cage position is anterior, you can get much better lordosis. So just to give one example of how lordosis you can get, and this is the patient which we had of L34 and L45, and you can see the difference that you can get a very good amount of a lordosis with the anterior cage position. So if you are into getting a good lordosis, you want a good lordosis, I think OLIF is one of the better approaches to get the good sagittal alignment. And you can see this is a positive balance. Just by doing a 3-level, you can get a very good segmental lordosis as well as a lumbar lordosis, and you can get a complete correction. So OLIF is good in all the aspects except it does not give a direct decompression. There is approach which goes through the abdomen, which is a big disadvantage. There is a fear of vascular injuries, and the corridor issues and the transitional vertebra is a big problem sometimes. Obese patients, if you want to traverse the abdomen through an obese patient, then also it is sometimes a challenge, and you may require a change of position. Of course, now we have a navigation, so we don't need to change them. We can do a whole single in a single position, the OLIF. But these are the disadvantages of an OLIF procedure. The latest addition to the interbody fusion is the endoscopic transcombine lumbar interbody fusion, where it is all percutaneous procedure. It is much faster than OLIF. It is much faster than TILIF. It is much faster than any of the other interbody fusions. It is facet sparing. It is percutaneous and endoscopic. There is a least bleeding, least invasive, abdominal sparing, single position, no dural or neuroretraction. It has a longer cage than TILIF but smaller than OLIF, and you can add an ipsilateral decompression, and you can do it at a multiple level. So there are a lot of advantages if you are doing these transcambine lumbar interbody fusions. So this is how we do it, the transcambine in endoscopic fusion. You start with the putting the wires. You start at around 8 to 10 millimeter, 10 centimeters from the midline. You put in the needle inside. You put in the wire inside. You start reaming the facet joint. So these are the reamers which reams the facet. Then you put in a 8.5 millimeter cannula, and then you have a disc clearance by the shavers and the curettes. And then once you have done a good disc clearance, you can check, put an endoscope, monoportal endoscope inside. You can check completely, complete clearance of the disc face and the end plate clearance by putting an endoscope. And then you can put and insert the bone graft. And through the 8.5 cannula, you can put the expandable cage. So the whole procedure becomes more or less percutaneous procedure. So this is with the 8.5 mm cannula that you can do, but then requires a specialized endoscopic instruments as well as an expandable cages. The other way that we are doing the same procedure is putting a fusion dilator. So after putting the wire, this is a fusion dilator which goes inside. So it's a half cannula. You remove the wire. This fusion dilator goes inside the disc space. You remove the inferior half, so this part will protect the exciting nerve root. So this protects the exciting nerve root. And once there is a protection, you can use all the standard instruments to prepare the end plates and the disc. So that's the shaver which goes inside, and then that's the box shaver. You can remove the disc there. That's a routine Carrison punch which goes, and that's the paddle shaver which goes inside. And then you can check the paddle shaver. You can measure the disc height. You can just rotate it. You can measure the disc height, how much size of the cage that you want. You can check, and you can see it's a very obese patient. And then you can put bone graft, and it's all percutaneous way that you can do this transcambin fusion. And then you put in the cage and you can check the stability of the cage. So this is a case of degenerative listhesis, and you can see that this is through the percutaneous way with the help of the cannula, and you can see how much you can get the expansion, and you can do a very nice fusion. So this is another case, grade 1 to 2 listhesis, and you can see a good amount of reduction. You can get it. Once you get a good reduction, you can jack up the disc height. Once you get the disc height, you have opened up the foramen, and then you can put in a percutaneous cage. This is a percutaneous cage which goes inside. So you can do it in all these cases. Again, the same type of case, I'll just go. You can do it at multi-levels. So this is a multi-level case, a transcambin multi-level fusion, which is this 2 years follow-up of the same patient with an indirect decompression of the post-op MRI, and nicely done. So a transcambin is one of the big game changer that I can tell in multi-levels, because it has got so many advantages. But there are some disadvantages of this procedure also. There is an exciting nerve root paresthesia in about 12 to 15% of the cases, and therefore you may require an IUNM, or you might have to do it under a local anesthesia. And there is a transitional anomaly. It is difficult to dock at L5S1 because it has a steep approach at L5S1. Reduced disc height, it is a problem. The biggest problem, again, what I'm going to talk about is the segmental lordosis and sagittal alignment, because ultimately it works like a TLIF procedure. So then we started comparing which is better, whether an OLIF is better or KLIF is better. And this is what we published in JMIST, comparison between the OLIF and KLIF, which is better for segmental lordosis and disc height. And definitely we had a matched pair between 50 segments of OLIF and 50 segments of KLIF. Disc height was much better, 103% with an OLIF compared to 59% with the KLIF. Changing segmental lordosis was much better in OLIF, but it was better than TLIF in 3.2 degrees, which was there, and overall change of lordosis, which was also better with an OLIF procedure. And why so? And this is very, very biomechanically. You can put the cage anteriorly in an OLIF, and then you can compress and can get a good amount of segmental lordosis. Well, the same thing is not possible there. So OLIF is better in all the parameters. And then we started comparing the TLIF, OLIF, and endo-KLIF. We had a 50 segments of MIS TLIF, 50 segments of OLIF, and 50 segments of KLIF. And we could find out that, of course, in this also, OLIF was better compared to the TLIF compared to the KLIF. So for all these parameters, when to do which procedure, and that's how we came to this algorithm, which I'm going to share as my last part of the talk. So if you see the indication comparisons, if you see the comparison multi-levels, definitely OLIF is preserved. Disc collapse, OLIF is, if you have a disc collapse, then OLIF is preferred. Foraminal stenosis, excellent by OLIF. Central canal stenosis, I think UBE or MIS TLIF, because you can do a very good direct decompression, that scores. Degenerative spondylolisthesis, I think OLIF is much better. While KLIF is not good, it has a limited decompression in central canal and moderate disc prolapse. There is a challenge, but in multi-level degeneration, it is limited. If you see the cage footprint and biomechanics, OLIF scores over the UBE TLIF or an MIS TLIF and a KLIF. If you see the sagittal alignment restoration, OLIF scores over the MIS TLIF and KLIF. If you see the mechanism of neural decompression, MIS TLIF or UBE TLIF gives the direct canal decompression. So whenever you require a direct decompression, MIS TLIF or OLIF or UBE TLIF is much better. But OLIF does not give a direct canal decompression. So it all depends on your indication. But KLIF is very, very limited when you require a direct canal decompression. Out of all the three procedures, if you see the surgical invasiveness, I think KLIF scores and no KLIF scores because it's minimally invasive. It has a very low blood loss, very less hospital stay, shortest surgical time, and fastest postoperative recovery. So whenever you have an alternative where all these things you have to see. So complication profile is similar, but they are different for different types of procedure. And this algorithm, what we are using now has been published in JMIST also. And I'm just going to elaborate on this algorithm, when to choose which type of procedure, considering all these publications that we had in different types of procedures. So if the patient is eligible for an indirect decompression, if the patient is eligible for indirect decompression, then you can go for an indirect way. But if it is not possible for not eligible for indirect decompression, you may go for a TLIF, which may be MIS or an endo. So this is where the first thing is. If the patient is eligible for indirect decompression, you check the vascular window. If there is no vascular window, then OLIF is not possible, and therefore you see if you are doing it at alpha S1, you check the high iliac crest. If there is a high iliac crest, then you cannot go for an KLIF. You have to go for a TLIF. But in the rest of the cases, like from 2, 3, 3, 4, 4, 5, you can definitely go for an endo KLIF, which is much faster and better procedure compared to the TLIF procedure. If you have a vascular window and if you are doing 1 or 2 levels, then any of the 3 procedures you can do, KLIF, OLIF or TLIF. If you have a vascular window and if you are doing more than 2 levels, that means you are doing a multi-level, I think TLIF is not a good choice for doing a multiple levels. Then you have to see the PILL in extension films. If you see the extension films, it's a flexible deformity. Then you can choose the KLIF when there is PILL mismatch less than 15 degrees. But if there is a PILL mismatch which is more than 15 degrees, there is a gross sagittal imbalance, then KLIF is not possible in multi-levels. I think OLIF is a much better choice compared to the KLIF or a TLIF in multi-levels. So this is our flowchart that we are using, and this is what we follow when to do a UB TLIF or when to do an OLIF or when to do an endo KLIF. But all the procedures, depending on the pathology and what you want to achieve, this is what I have made these algorithms for our routine clinical practice. Thank you very much.
Thank you very much, Professor. Very complicated and complex topic. You made it very structured and comprehensive for the audience. I appreciate and want to express my gratitude. You didn't just say that which one is superior, but you dissect it in all directions, whether it's clinical outcome, whether it's short-term or long-term outcome. I have just one question till we see questions in the chats. For young neurosurgeon, especially interesting for me was the learning curve. And for endoscopic one, it said more than 89 procedures, while the other one had like 20 to 90, 20 to 30 procedures. So I'm asking from the point of view of young neurosurgeon and others in the audience, is it worth to spend the time and longer learning curve if you the
This
long-term
learning curve
outcome?
was
Yeah.
definitely because endoscopy is the way to go. It's a way
Mhm.
to go because that's how the whole thing is changing. It has much better vision. You can go to the corners, and you see, for any procedure, this 89 was as a second level because first 80 procedures you are doing only a discectomy or a decompression. And then you go for the TLIF procedure. And that's why the learning curve is much more. So the other important aspect is how you are trained in your primary whenever you're doing your primary degree. If your mentor is doing an endoscopy, you will learn it much faster. If your mentor is doing an MIS TLIF and then you want to change to an endoscopy, then your learning curve is going to be much longer. But definitely, if you want to start learning, endoscopy is much, much better as on today. And you have to start with that procedure. There is no doubt about it. Because
Thank you
it
very
gives much better result. It is much more minimally invasive. It has a good visualization, good clarity, uh, good magnification. You can go inside the disc space. You can go to the corners. So there are a lot of advantages. So not only the surgical advantages, but the clinical advantages also, because the patients are going faster, they have less pain. So the patients perceive it as a much better procedure compared to the other. So there is no way that you have to learn the endoscopy.
Thank you very much for your response. Uh, Professor Suju, would you
Uh,
like to comment or ask a
Dr.
question?
Amit, first of all, can you please stop your screen sharing so we can see each other larger?
Yeah, sure. Yeah.
Thank you so much. I want to ask that, isn't it possible to turn the key leaf when you put in the disk space? I think maybe it can be produce some key leaf, and you can put inside of the disk space, and then you can turn it just as in the TLIF procedure. Isn't it possible?
So
Is it
turn what? You need to turn the cage?
Yeah, and if you
Yeah.
turn and if you put it to anterior column to the anterior,
Yeah.
you can.
Definitely. So in Caliph procedure, what we do is a reverse orthogonal procedure. So once it goes obliquely inside,
Yeah,
then we turn the handle down
yeah.
so that we make it much more horizontal to make it much more anterior. So this is what we do always doing in the Caliph procedure.
TLIF procedure, T.
Yes.
And why don't you can't the same in the KLIF?
You can do the same thing. You can put the cage anterior, but the cage size is smaller compared to the olive.
Yeah.
So the cage is not that big. The other thing is the anaplate preparation is much better because you are doing direct in olive. You are not doing a direct, you're not having direct approach because there is going to be a dura, there's going to be the root, which you cannot retract much.
Okay.
While in olive, you are direct anterior, so you can do a much better clearance.
So the main difference is coming from the cage size.
Cage size and the approach, which is much more anterior or lateral.
Okay. And
So biomechanically, you can put the cage much better position compared to the TLIF or a K-leaf procedure.
And my second question: how can you decide the indirect decompression is enough for the patient? How can we decide this? Is there a certain radiological science or clinical
Right.
science?
So it is more of I would say a philosophy. Lumbar canal stenosis, the clinical symptoms come as a claudication.
Yep.
While in disc prolapse, the clinical symptoms come as a radicular pain. The claudication occurs only when the patient stands and starts walking. There is no rest pain. While in disc prolapse, the patient has got a rest pain also. So that's how there is a difference between a lumbar canal stenosis and the disc prolapse.
Yep.
So basically, it is not a radiological indication. How much is the compression? That's not what we see. But we see the clinical condition of the patient. If the patient does not have a rest pain, if the patient has got a claudication, then that patient is good enough to get an indirect decompression.
Indirect.
But if the patient, yes, that means you can do an olive procedure.
Okay.
Because even if the patient is in MRI, patient is in lying position, patient does not have pain, whatever the compression it is. At rest, we do an MRI, the patient is off loaded and the patient does not have pain.
So, as I
Rest
understood,
pain, rest, patient should not have a rest pain. That is one of the big clinical indication for going for an indirect decompression rather than seeing the MRI.
okay, in summary, if the main complaint is neurogenic claudication, you can do indirect decompression.
Decompression.
Thank you.
Yes.
Thank you so much. It was a really teaching conference for me. Thank you so much. Also, I am happy to meet you in Mexico, Dr. Amit.
Yeah.
Thank you so much.
It was a nice time to have together at
Yeah.
Mexico.
Yeah.
Yeah. Right.
I hope we can do it again in somewhere.
Yeah. Sure.
Okay. Efecan, would you like to say something? Efecan is doing UV surgery in our clinic. It's a young neurosurgeon, and I am doing them only monoportal.
Oh, okay.
Thank you, Professor Amit Jhala, for this lecture. I think, as well as you, the UB procedure is effective in fusion procedures. We want to learn.
You have to learn. You have
Yeah,
to.
thank you.
Okay. Thank you so much.
Thank you very much. Thank
I
you.
also want to thank everyone who joined us this evening.
Thank
Okay.
you.
Hope to see
Thank
you
you very much.
again in
Bye.
a
Bye.
near future.
Bye. Thank you.
Thank you.
Bye bye.
Bye bye.